think in the end, what will end up happening is that diagnostics or clinical decision-making, the median should rise. We should start seeing people making better decisions informed by this type of information, and do so pretty broadly, right? So this should not be limited only to the quote-unquote best centers, right? This should be available to almost all pretty quickly.
Welcome to Unnatural Selection, a show about competition, innovation, and the strategies shaping tomorrow's frontiers. I'm Nick Encina. Each week, we speak with pioneers shaping the future.
This is episode 28. For most of modern medicine, decisions have been shaped by what a single clinician could see, remember, and carry. That worked until it didn't. Today, the pressure isn't just on biology, it's on how information moves. Digital health platforms are quietly becoming the nervous system of care, linking signals from individual bodies to patterns that only appear at scale. Verily sits right at that edge, where software culture meets the realities of medicine. Andrew Trister has spent his career crossing that boundary, from Apple to the Gates Foundation to leading scientific strategy at Verily. In this conversation, listen for how places with fewer legacy systems sometimes move faster, and what that teaches us about building health systems that actually learn. Andrew Trister, MD, PhD, is the Chief Medical and Scientific Officer at Verily, where he leads the company's research, science, and population health initiatives, providing expertise across Verily's portfolio as the company furthers its precision health strategy. Previously, Andrew served as the Deputy Director of Digital Health and Artificial Intelligence at the Bill and Melinda Gates Foundation, where he led the foundation's development and investment in digital health and artificial intelligence to address global health inequities. Prior to that, Andrew was a founding member of Apple's health team, where he led clinical research and machine learning with Apple partners. Andrew holds an MD, a PhD in bioengineering, an MSc and BSc in computer science, and a BA in biological basis of behavior from the University of Pennsylvania. He completed his clinical residency in radiation oncology at the University of Washington with additional focus areas in medical and bioinformatics. Let's go.
Andrew, it's a pleasure to have you here. Thank you for being on Natural Selection.
Thanks, Nick. Great to be here.
Just to kick off and level set to give people perspective on what drives your work, could you please give us a sense of what need or impact drives what you do?
Well, since I started in undergrad, focusing on engineering and pre-med classes, I always had this idea that it might be possible to better care for people using technologies. This was during the second winter of AI, so in the late 90s. So there were some applications that we could work on primarily through computer vision in the computer science lab. But I was running from one part of campus to the other, focusing on, can I build an artificial neuron in computer science? And then can I study what a neuron actually does in a physiology lab as part of the neuroscience, the BBB major that you mentioned? And I have to say that back then, it was almost impossible to imagine how quickly things would shift. The digitization of tools that we use in the clinic and the ability to leverage all sorts of new sensors have really changed the way that people are cared for, everything from diagnostics all the way to care in the home. But the thing that really has driven me in all of this has been about finding ways to make access to those tools and to the best decision-making possible for everyone. So in the move that I had from Philadelphia to Seattle, there's a massive shift in the practice pattern. Philadelphia has many academic medical centers, all within Center City, competing for one another almost in catchment areas measured in blocks, not dissimilar from Boston. In Seattle, it's quite different. There's one academic medical center for 5 states, and those 5 states amass about 25% of the land mass of the U.S. So people were coming to Seattle from really far-flung places compared to what we may have seen in Philadelphia or in other parts of the Northeast. And in that, we very quickly realized that the ideas of what we were able to accomplish in primary care and building and even rural medicine programs could be augmented very quickly using digital tools. So in those focus areas of medical and bioinformatics during my residency and postdoctoral years, a lot of the time was really spent on finding ways to help those who may not necessarily be able to come in to the tertiary and quaternary care centers that we have set up in our system, but still make medical decision making possible for them. So give back agency to people that may not have that ability today.
That's interesting. So that taps into potentially rural care using digital technologies to be able to, I guess, meet patients where they are, right? Not necessarily expecting them to come to your centers, but saying, how do we help people where they live, and in some cases, ultra rural conditions as well, which I know a lot of people are working on today. So,
Exactly right. So one of the things that we saw even in those earliest days was that the VA system that's based in Puget Sound is part of Visit 20. They had spent a tremendous amount of time really focusing on how is it that telemedicine can augment the type of care. So rather than having to shuttle people outside of their home or out of their communities, really bringing the care to them when they most need it. And that was, I think, quite pioneering at the time within the VA system, and certainly impacted a lot of my own understanding of ways that technologies can make a difference.
I mean, very pioneering because you said this was the 90s, right?
Yeah, this now is into the 2000s, right? So
Okay.
starting in the 90s and going into the 2000s.
I mean, nonetheless, that was still, even if it's 20 some odd years ago, the internet wasn't even what it is today, right? I mean, just even connectivity and all that. So this is very pioneering, thinking about how to use digital tools to try to bring care to people where they are. So if we turn to your work now at Verily, for audience members that may not be familiar with Verily, can you give us a quick overview of what Verily does, and more broadly, what the health data industry is really about?
Absolutely. Verily is one of the companies within Alphabet, previously known as Google. It was one of the first to come out of what was internally known as Google X, or the Moonshot Factory, an incubator of different technologies that actually spun up quite a few different projects, both within Google itself and then as separate companies. So when Google reorganized itself into Alphabet in 2015, Verily was one of the very first companies to be included in what we call internally the other bets. Right, so these other companies that would take on things that go beyond internet and search. So we had the benefit of the DNA of the company, very focused on data and data science, to impact societal questions. And the focus of Verily has been to build platforms and tools to demonstrate how is it that we may be able to help people make medical decisions, everything from along the way from different kinds of sensors. So inventing hardware devices that people can wear or put on their bodies to introduce new understanding of long-term physiology, all the way to actually delivering care. So we have a medical group that cares for people with currently type 1 and type 2 diabetes, and expanding this fall into medically assisted weight loss and cardiometabolic disease. So it sort of covers as one would expect, a large tech company goes after the full waterfront of all of healthcare at once, which is quite a privileged position to be in. So I joined Verily 2 years ago when the shift was really going away from building devices more and more toward how is it that the data that are generated both within the health system today, so everything from the health record to care utilization patterns and claims, can be combined with the sensors that people are increasingly wearing. So that could be anything from a Fitbit or an Apple Watch, I guess Pixel Watch, all the way to CGMs, right? Continuous glucose monitors have become increasingly useful. And so we're building a data science approach to supporting merging all of those data together and making new insights to better allow physicians and people themselves to have agency in their own care.
That's great. And just for a little bit more clarification for me, I'm very familiar with the Google ecosystem. As we talked before, Google Ventures invested in my previous company. It still sounds like Verily's a bit of an innovation lab because um, I mean, you could go one direction, which is you're building the tools to discover drugs, in which case you're becoming more of a biotech company. It doesn't sound like that. The other thing is also maybe you're building these tools to license and sell to pharma companies, which takes you down the path of like medtech. It doesn't sound like that either. You're not a diagnostic company necessarily. And so, like you said, you're kind of like in a bunch of different fronts in healthcare to see what works. Do you have a particular client in mind? Is it the healthcare system? Is it pharma? Is it anybody? And does it operate like an innovation lab where you're seeing what works, maybe taking a portfolio approach to the discovery, and then when it does work, then you figure out where to place it? I guess I'm trying to think about the strategy that Verily takes.
Yeah, it's a great question. I would say that the strategy has shifted over those 10 years. So in the very beginning, it was really focused on individual client areas. So there was a team focused on healthcare systems and how can we bring new data products into the healthcare system itself. We actually had a few years ago, though we just divested this business, a focus on insurance. So we had a stopgap insurance program that allowed us then to work with payers in a different format, right? So to offer the secondary insurance necessary to provide stopgaps. We did work with pharma and we continue to work with pharma extensively, more on the focus of how can we introduce new digital measures to help to augment their understanding from patient selection, say for an early stage trial, all the way to post-market surveillance to understand how their medicines might be working. We work with med tech companies as well. In fact, one of the probably highlights of the history of Verily has been working with Dexcom on a continuous glucose monitor, which hit the market as the G6. So a lot of the engineering work that went into miniaturization came from Verily engineers as a partnership with Dexcom. So in the totality of the history, it really did begin as an innovation lab, not dissimilar from X, but with a very focused area on healthcare innovation. And as the company matured over the 10 years, and particularly as forced by the exigent circumstances of COVID and the global pandemic, there was a uh, reorganization of the company starting in 2023 that allowed, so this is right as I was coming on board a couple of months before, where the focus really did shift to say we don't have to invent the devices necessary to make these new measurements available. Instead, let's take advantage of what we have already learned from building such devices and see ways that we can help to introduce these insights into the workflows, whether that's for clinicians, whether that's direct to patients themselves. Uh, and so we really think of ourselves now as a platform company that has emerged from the experiences that we had in the first party. So really, our customers could be, yes, health systems and pharma companies, payers as well as those who are now innovating in this space and don't want to have to think through all of the regulatory difficulties that might come with building AI tools or potentially wanting to build a new way to impact patient care. They can do so on the platforms that we've built as a third party application. So that's the new area that we have been focused on. So we continue to innovate to learn, and then we also hope the ecosystem can benefit and bring things to market more rapidly.
That makes a lot of sense. Thank you. And so I guess if you're still operating somewhat like an innovation lab where you have multiple obviously projects going at the same time, how do you think about it, and especially you because you've been there for 2 years and you run the science effectively. How do you think about balancing kind of long-term moonshot research projects, the Google's known for, but then also with kind of like near-term impactful products and product launches that kind of show progress while you're working for these, cure cancer kind of moonshots?
Yeah. So this is a constant dance in any innovation frame. This is true also at my work at the Gates Foundation, that we have to demonstrate some near-term utility. And I'm very fortunate to work with an old friend and partner in Myung Cha, who's our chief product officer, who joined just over a year ago. He and I go back to our days at Apple together, helping to start the health team. And in that, Myung's real remit has been to bring the products to market in the near term, right? So my focus can be left. It's again quite privileged, but can think through a 3 to 5 year horizon. So thinking about what is that next horizon, where is it that things might be going. So try to look around the corners, and I built a small crack team to really focus on that, while also understanding the typical tech approach, right? To ship and iterate and learn from customer feedback. So our products and tech teams work really, really closely together to build the new technologies, ensure that they get into the market and have some value for people. while we can do some more of the science experiments, which right now, with a lot of the work going on in generative AI, has been increasingly focused on ways to build automated evaluation frameworks and to help to ensure things about safety and utility of tools that might come out as, say, a chatbot instance, as an example.
Hmm, interesting. And then do you have, as part of Verily, do you also adopt some of the other healthcare initiatives that Alphabet has been involved in? From, Alphabet has a long history in healthcare, from personal health records to protein folding problems and so on. Do you work on any of those? Did you inherit any of those, or are those managed separately within the Alphabet ecosystem?
Yeah, so Verily as a company separate from Google did have some things that were competitive. I would say that in the 2 years that I've been at Verily, we've had more and more effort put across Alphabet to really share innovations that we're working on, to talk about strategy openly across the Alphabet companies as much as possible, since we are still separate entities. But indeed, companies like Isomorphic, which spun out of DeepMind, to leverage some of the AlphaFold technologies on behalf of pharma companies, that seems to be a really good fit for early stage target discovery and potentially doing computational chemistry to inform uh, potential chemistries to eventually become a medicine. That's much more early stage than we work, but we could work in
Mhm.
parallel with them as they're working with those pharma companies to help to think about who would you identify or how would you identify patients that would best benefit. Since increasingly, as we think about precision, uh, kind of a cruder way to think about precision would be that you're really down selecting people. Right. So in some ways, it's really, I mean, if we get down to the N of one, which is fantastic on many, many factors that we can tailor medicines for a specific person, that the economics of that make it quite difficult to think about how do you do that sustainably. So we play a role there. With Google Health, we partner very, very closely with them. We don't have much impact with respect to the Google assets, say search or maps or other tools, YouTube in particular, where there could be a public health intervention by ensuring that the quality of the information that's shared is of the highest bar. Instead, we work together with the research teams that have been leveraging some, again, mostly generative AI of late, um, but thinking ways of leveraging some of the tools like Amy and MedGemini, which have come out of the research efforts across Google. So we think about the products and how is it that could come to market in a different way.
And you mentioned there that some of that early discovery stuff is before where Verily focuses, right? So you presumably come, would you say at like the clinical trial level and beyond, or whereabouts do you think Verily starts?
Yes, I think for pharma companies, absolutely, clinical trials are where we would begin. We had efforts in the past that would be much earlier, but I think that this has been a sweet spot where we think about the technical interfaces with people. And so before a person might enroll in a study or before a person becomes a patient, we can help to inform some of the background, what is happening with them and why would they necessarily benefit or should they participate in the study to help to inform downstream decisions. That's the kind of thing that we do quite well. Some of these other elements, I think we were actually quite good at, but it's a lot for any one small company to take on, and so we feel like we have been able to ourselves focus in on the area where we can bring the maximum impact and allow us to really go deep instead of broad.
And you mentioned they're working with your chief product officer and coming up with that kind of 3 to 5 year horizon portfolio. Obviously, without revealing any competitive intelligence that you have, what does that 5 year horizon look like to you with respect to, and I guess really more specifically, precision medicine, because that's really kind of Verily's focus, right? It's really how do we use an approach of precision medicine, and for those people listening, the audience for this podcast is very diverse. um, I classify this precision medicine as using all sorts of data, not just clinical, it could be environmental, it could be behavioral, it could be genetic information, using advanced algorithms to come up with more and more refined ways of risk stratifying people. So you can identify effectively what your preconditions may be. How do we monitor? How do we intervene? How do we cure some things? And then the more data that we have, the more refined those models become. And so this is where Andrew was talking about getting down to an N of one would be like, we know you so specifically, we can tell you specifically and precisely what's good for you, and maybe even design drugs specific to you. The economics of that are very challenging still. And so what we try to do is kind of come up with a balance of what's good enough to risk stratify a segment of the population that's refined enough so that we identify real risks and get ahead of those, but not go overboard to the point that we're kind of really, getting down to numbers that invalidate the economics of the approach.
Perfectly stated. And one additional piece that I'd add to that is that as we think through the economics of healthcare, that we continue to have some really fundamental structural issues, right? So since the end of World War II, healthcare costs have increased year over year in a super inflationary rate for all years except for maybe two. And in that, a lot of that comes down to, Econ 101, right? So I'm not an economist at all. So this is not my realm, but you can sort of understand it, right? Is that the demands have completely outstripped the supply. We have a workforce shortage that's global, and certainly true in the US. Things are incredibly um, non-uniformly distributed, as I was alluding to earlier. The differences between what we were able to provide in Philadelphia or in Seattle versus, say, the more rural areas, as we're talking about. And in that, we also understand that there are incredibly heterogeneous outcomes. All right, so the precision piece had been identified as a potential area of intervention now, I think 25 years ago, right? So what is now the National Academy of Medicine, then the Institute of Medicine, published a report that introduced this idea of the learning health system. It was the foreshadowing of what would happen if we were to digitize all of the information that was happening, whether it's biology or individual genetics, right? This was at the time of the Human Genome Project, and getting all the way through electronic health records and other things that were standard in the health system, but in a way that would allow us to better care for an individual person. So rather than take, say, the knowledge of a single physician, which is limited by their own experience and whether that's book knowledge or experiential knowledge, there's all sorts of biases that we have, whether it's diagnostic or we didn't read the latest paper that there's a better treatment or whatever it might be. That humans have fallibility. So there was a promise that you may be able to build a system that would allow for physicians to help patients take better care through using the information that was in real time happening across the entire country or potentially globe. So that idea of the learning health system took research out of the confines of just a really narrow clinical trial and started to introduce this idea that there was evidence being generated all the time, right? We now call this real world data or real world evidence, if you want to go all the way to regulatory, uh, to help to inform clinical decision making. We believe that the platform that we've built supports that kind of system. Right? This has been a kind of the holy grail problem for a lot of medical informatics for quite some time, well predating that IOM report, and yet it is still elusive, right? And in large parts, it's because the data infrastructure are not uniform. Right? Health records are not things that from one health system to another are the same. Right? So we've built interoperability standards. We've allowed some liquidity of data to flow from one health system to another, increasingly now to people. Right? And we really applaud CMS, the Centers for Medicare and Medicaid Services, just a month ago announced efforts that in the next year, people should be able to gather their health records in a way that they can read them and that their physicians can read them and share them broadly. This has been a long time coming. There's been a lot of effort to build those pipes, but we'd see this as the continuation of, okay, so now you have records that can move. How can we put the informatics piece on top of it, just as you were alluding to, right? This data science component to learn. quickly from large masses of people that are outside of clinical studies and help to inform what best to do for a person. I think in the end, what will end up happening is that diagnostics or clinical decision making, the median should rise. We should start seeing people making better decisions informed by this type of information and do so pretty uh, broadly, right? So this should not be limited only to the quote unquote best centers, right? This should be available to almost all pretty quickly because data and information flow pretty uniformly right now, thanks to the internet and those technology shifts.
Interesting. So would that be characterized maybe as one of your horizons, which is that, um, if I paraphrase, you have been working on the technology to be able to analyze the data and come up with insights, health insights, and do better risk stratification and recommendations. The limiting factor has been the data, because it's been siloed, it's been in all kinds of different formats, difficult to access, and so on. Now, with the new CMS approach, over the next couple of years, that should ameliorate itself, and so you should have better access to data. And so, is that kind of where you're seeing that horizon and Verily's approach to, as you called it, a platform company? You're building the platform to be there and ready for when the channels of data start becoming available.
Exactly right. And I'd say this was also informed by part of the reason that I went from Apple to the Gates Foundation. So that was a shift that I took about 7 years ago. And in that shift, there was a couple of things that I was recognizing. The first was that um, in the global south, and the Gates Foundation primarily works in, at least in the country spaces in sub-Saharan Africa. There were 3 or 4 countries with really deep expertise, and in South Asia, and primarily in India, a lot of focus on digital applications for health. That there's work that the Gates Foundation does outside of those places, but when we identified where we could work, from the digital health and AI perspective and building innovations, we saw that there were certain substrates that were appropriate in those places. And there's a history of what has occurred in the global south when it comes to connectivity and introducing technologies that didn't require shifting from incumbency, right? So, for example, a lot of these countries did not have copper wire that connected people for telephone, right? And so rather than building that infrastructure first and then going to cellular, you can sort of do a leapfrog and say, okay, I'm not going to build the copper thing, which is very labor intensive. We can still instead put cell phone towers and focus on that. And very rapidly, you see this adoption of cellular phones as the form of communication, even among those who are at the, on the first rung of the economic ladder, right? So earning $4 to $6 a day, and that sets the stage, right? So while it's true that CMS and the regulations here should allow for this liquidity, what even 7 years ago you could identify was that the way that the global majority were gaining their care was in the community, but the people who were providing the care were not necessarily doctors or nurses, right? So it was a community health worker or volunteer who was close to the community, either living in the rural village or nearby, itinerant workers who could come by. And the question was, could it be possible to augment, right? To build the data infrastructure that you're describing almost as a leapfrog to say, we're not encumbered by a health record that's quote unquote owned by the health system in a brick and mortar hospital. Instead, you have an itinerant worker providing care already using mobile devices. Could you build the equivalent of health record, whether it's personal health record or the EHR, if you will, it helps to inform the decision making at that point of need. And the thinking always actually that I had at that time, and I still think it's valid here, is that would be a model for how we could deliver care in the U.S. as well. Right. So coming back to the what drives me, the idea was we can help people and learn, and also to help to transfer some of this infrastructural knowledge back into the U.S. health system, where it would be displacing incumbents. I mean, it would be difficult to do, but we're also seeing that it's governmental actions can also help to bring transparency and action for people as well, faster than it would be like a grassroots approach. So I think Well, again, I laud these decisions, and I do think that it will be a significant thing in the next 3 to 5 years in the U.S. It is also a matter of paying attention to what's happening in other parts of the world, India in particular, where I spent quite a lot of time and focus for the last few years, has really moved very, very rapidly to building infrastructure to support exactly this kind of approach with agency and autonomy for individual people, uh, so that the government actually acts as a fiduciary for your health data. All right, so that has an advantage over what we have, which is this complete federated thing. There, if it as it rolls out, the idea would be that the government of India actually can, if the states agree, can hold the data on behalf of an individual citizen, and then that citizen can decide who they want to share that data with. So if it's for their own health reasons, if it's for a loved one that maybe there's a genetic issue that needs to come about, or even for research purposes, ultimately they have the control of where the data flows. It's a very, very interesting model, a bit further downfield from where we are at the moment, but something again that we can observe, learn from, and then take back for our citizens if we agree. And this is the approach that we could do here.
Yeah. That's fascinating. Yeah, it's an interesting dynamic, right? I mean, we talk about as technology evolves, early adopters with the financial means and infrastructure means, they take advantage of that, and then there you create this big chasm between those that can and then those that fall behind, and so that's always a concern. But then that creates an interesting opportunity then that as that stretches out, eventually you can leapfrog. And I see it also. I run an international consortium in newborn sequencing, and a big talk there is obviously newborn screening's been around for 60 years or so, and a lot of the advanced countries like the U.S. and places in Europe and others have been adopting that and implementing it for a very long time. Many other countries have been left behind, but now there is this interesting place where, as genomics becomes more accessible, they're starting to think, well, do we need to build that infrastructure to begin with? And if you think about it, those of us that have that infrastructure are in a way a little bit almost hamstrung by it, because that infrastructure and the public health system is not built to support genomics. And so now we have this kind of weird challenge, which is like, how do we adopt the future without having to reinvent the entire infrastructure that we have? Other countries are like, well, maybe we just skip that altogether and go straight to genomics.
Exactly. Yeah, that's a great example, and definitely something that we've seen happening across a lot of healthcare systems. I think one of the lessons that I learned during that time, and I think is relevant here, particularly to the work at Verily, is that there were also many great ideas that just never amounted to much impact. Right. So this was in the global development space. A lot of people talk about these as pilotitis. Right. So the idea that you run a pilot in a place, and and usually very highly selected, right population, right mode, government approvals, money, et cetera. But then it never scales. And with digital tools, if you can build them already with the scale in mind, right? We have built an infrastructure that's at the same. I mean, it's literally the same team from Google Cloud that built the health infrastructure 10 years ago at Google Cloud. Those are the engineers that are at Verily. So they're thinking at cloud scale, right? It's again incredible privileged space to be in. But even though we are only now launching this, the expectation is that it could potentially have huge numbers of people that could benefit from it because it was built to scale that way. If you don't build from the beginning for the large scale impact, the lessons are that you end up getting hamstrung, just as you're describing. Of course, 60 years ago, there was no way that we could, predict genomics and the revolution there. But the same idea is happening, that as we're on this exponential of the sigmoid in terms of change, particularly in the generative AI space, although a lot of other technologies too. Right, medical technologies are sort of overshadowed by the AI technologies, but so many amazing technologies are becoming available. It feels like every couple of months there's another landmark paper about a shift in our understanding or a new diagnostic. How to get those out to people is the limitation, right? Just look at GLP-1s, right? And the limits that we've had and the needs for compounding and so forth. And even if Lilly and Novo lower the prices even further than they have already, recognizing the potential for societal impact of these medicines, the reality is there are not enough physicians, right? There's no way to identify who is actually going to benefit, and then how do you help to frame the side effects and help people manage through. And those are the kinds of questions that you were asking, the 3 to 5 year horizon. We're starting to tackle those types of questions. When we think about the large scale societal impacts of the technologies, how can we anticipate what they will be, and how can we feel that we can engender trust in whatever we build or help others build, uh, to address whatever limitations might exist.
Interesting. And you mentioned there about the pilots that are built without necessarily thinking about scale, and you guys are obviously getting ahead of the curve there. Another challenge is often, obviously, we're in healthcare, and there are cultural barriers, there are bureaucratic barriers, there are regulatory barriers. So, given that healthcare is typically slow to adopt new technologies for many different reasons, what's your strategy for breaking through some of these cultural and bureaucratic barriers to innovation and adoption? Do you think about those ahead of time before you start productizing and launching?
Yeah, we do. Although we also realize that we have to come with some humility, that there are things that we believe should work that just will not get adopted. So there has to be a mindset of let's build what we think is best. We always partner. So whether we're working with health systems or public health officials, we happen to do quite a lot of pathogen surveillance from the time during COVID that we continue to do for public health officials in states and counties and with the CDC. And in all of those, I would say all of those projects represent really strong partnership. So we have to go with our ideas and the potential for what we could build, but also to listen carefully to what the problems are, because very often I think as a I would say societally we fail in innovation to look around in other domains, to understand that some problems that we might define as a healthcare problem might actually be one that is already solved in a adjacent domain. But there are very few people that speak multiple languages. I mean, I really applaud you for doing this type of podcast and bringing people on, because that's exactly the type of thing that we need to cross pollinate and to learn. And so if we open our eyes and hear, here's the domain of issue that we might have in the health system, very often it could be a much simpler problem than, throw a large language model at it and, expect that to fix the issue. Even though that might be in vogue right now, the reality is that the real solutions might be something a bit more mundane about, just get a better staffing model or figure out a logistic regression on some data that might be able to help you best classify someone. These are simpler tools, but we often go after the shiny object in an innovation frame as opposed to innovating through learning across, listening and learning from other people.
Yeah, yeah, it's we're always drawn to the new shiny stuff, and especially if you're in a startup, you have to go for the shiny stuff because that's how you get investment from VCs. But in many cases, and I spent a big chunk of time at Ariadne Labs, School of Public Health, and the work we do there is helping to scale innovations in healthcare in ways that are accessible across the world, right? So things like checklists. There's nothing sexy about a checklist. You're not going to get VCs to invest in that, but sometimes that's really all you need to make sure that mentally, you get, say, surgical teams to communicate, right? Just kind of break down barriers around like what a nurse can say versus a surgeon. It's like, no, actually, everybody's responsibility is to make sure we check off this checklist. And so, really, a lot of the work that we did was really trying to break down communication barriers, believe it or not, in most of the things that we did at Ariadne.
One of the my favorite papers from your work there was the Better Birthing Checklist work
Oh, yeah.
that was done in northern India, also funded by the Gates Foundation. That predated my time there, um, but it demonstrated exactly what you're describing. But it also had this really interesting nugget, and that was the fact that you can improve outcomes for people, but only when you actually had the health workers available to them. So those people who are even in these really I would say difficult situations, right? Rural settings in northern India, the people who are at the lowest caste, right? So really far away from the center of the village, a far distance, the health workers were less likely to go and walk the 10 kilometers to their home. And so even if you had the checklist, you still needed a way to deliver it and the person to be there. So outcomes did not shift when you looked at the sub stratification of people who were the least empowered, right? And so that's one of the things here that we are always thinking about, is there some way that a digital tool actually allows you to overcome some of those structural barriers that exist, whether that's societal barrier or just the physical distance or things like that. But it holds promise. We just haven't been able to demonstrate that that's really the thing yet. So I think that we're starting to stack all of these, you know, really amazing experiences to demonstrate, yes, there are ways that we can overcome some of the structural issues, but some of them remain. And then we have to think about the next thing. That probably I would say is a microcosmic truth about AI. Right. I mean, when I teach classes on this or have interns or even some of my team, we talk about what is the utility of AI. There was a really long history in academia of recognizing that the ability of a classifier that's trained on the data that we generate, through the internet, let's say, like a large language model, that there are biases, right? So a very famous example of this was actually one of the first transformer models, the ones that predated the large language models had a really nice translation function. That's really what they were built for, right? So attention is all you need. 2017 paper demonstrated this ability to build a statistical frame to translate from one language to another, right? Really powerful work. And there are certain languages that have agendered pronouns. And so now the question was, if you were to say, I want to translate from the word nurse in English or the nurse in Hungarian, let's say, agendered into English, what gender would you put around that, right? Or doctor or mother, obviously, is an easy one. But you start to see that there are these biases, right? Nurses were overwhelmingly women, doctors were men, engineers were men, things like that. And that was astonishing. And there was a lot of work that came out of Stanford at the time that said, well, we can remove the gender axis in this hyperplane. And it's great to show that you can actually measure it and you can then remove it. But the question is not that. It's more, would you want to do that, or do you just reflect the fact that the transformer is showing the biases that exist in our society and the way that we speak about these professions and the approach that we take? And to understand that as humans, that this is a tool that then gives us a new way to measure the things that may have been unmeasurable, like knowable for sure, like kind of, this is an example that I think most people would understand immediately. Um, but rather than remove it from the model, leave it, but understand, use it as a lens, right, or as a mirror to what our society is. And I think that that's actually what's going on now with every next generation of these large language models. They're representing more and more of the biases that exist in our societies, and as they continue to demonstrate really amazing abilities, not quite superhuman yet on most, the reality is that they also fall apart. So like the next thing to go solve becomes very evident because they're not thinking machines, right? These are not actually artificial intelligence in the way that was described in the 1950s. So in many ways, I think that same, because it is actually still this roughly the same technology. There's just much more data thrown at them. These things remain a reasonable mirror for what it is that our society has written about or holds as part of the compact. And we have to recognize that that is one of the major limitations that they have, right? So this is where it would be hard to say these tools are going to overwhelm our ability to care for people in healthcare, but instead we should say they are tools to augment the providers that already are providing care, right? As an example. And so these are other issues that we are trying to face. Like, how is it that we get to a point of being able to augment a health provider appropriately, because many of the ways that these tools have been trained are to leverage language in a way that seems really erudite and very, very trustworthy, even if it's a complete fabrication. I don't like this term hallucination that fell into the literature, but it's like a total fabrication of something, because it's a statistical model at the end of the day. It's not actual knowledge of the concepts. And yet that's what we carry. We have knowledge of concepts and we can put concepts together. The technology will continue to improve. There's no doubt. And at some point, it will be able to do things that maybe we cannot imagine, as it does now. There are things that are completely superhuman in the capacity of these models. However, the understanding of when is it that this is giving an answer that might be a fabrication is one of the things that we have to resolve quickly, right? Because at some point we're going to lose expertise to be able to evaluate. And that becomes, I think, much more dangerous when we think of life and death situations or diagnostic dilemmas or things like that. So incredibly powerful technologies, but still a reflection of the limitations that we all carry in society and our own knowledge at the moment, right? So it's not suddenly like coming up with a cure for cancer on its own. In other words.
Yeah. Yeah, and it's almost like these models fall into the local minima, statistical local minima that they can't get out of, and so we have to build higher level thinking to say, well, let's check other parameters to see is that really the answer or are there other ones. But you've been so generous with your time, Andrew. If I can just finish because you touched there on society. So if you and from your perspective, you've been at Apple, you've been at Bill Melinda Gates Foundation, and now with Verily. So if we look out 10 to 20 years from now, what's the single biggest shift you expect to see in how we as a society approach and manage health? And what do you think people today are underestimating about that future?
That's a great question. 20 years out, I really believe that what we will see is a different compact between the current agent model that we have, right? We currently have a principal as a person that needs help and an agent, doctor, nurse, extender who can provide that care. And that's largely because of the asymmetry of information, right? The amount of training necessary to get to the point of being able to answer that question. I think that these innovative tools are shifting that asymmetry of information to the point of maybe not even existing anymore, that anybody can gain access and maybe I become my own personal best expert on my own health. I'm empowered then to make decisions. Now, we still will have regulatory restrictions, I think, in 20 years, so that I can't just go out and take whatever herb, drug, supplement, whatever that I think I need. But I think that will allow us then to get back to the very human components of empathy, of bearing witness, of these things that were a big part of medical practice, and still remain. I must say, it's not like it's lost, but the humanity of it, the art of it, is what is going to be very very difficult to replace, right? So that element, I think, is going to become more what people will seek when they come to the physician, right? The counseling, and potentially some of the gatekeeping for some of these things. But I think that people will feel much more empowered to drive the discussion, which we have wanted. I must say, like as physicians, this has been a big part of the discussion. Shared decision making has been a big topic of discussion for decades. And I think that these tools will allow for that because we will have access to information that we can't even imagine now, right? The longitudinal physiology, every measurement known possibly, and would require superhuman intelligence to even figure out what does all of this mean. So getting back to your point on making better precision around risk and then taking action about that, understanding uh, for myself what it would mean and how can I take something to shift my risk will be the larger part of what we can do in medical practice, and I think it will allow for a greater level of connection between people, between whether that's physicians or nurses, other extenders, or whether it's a person just seeking help from others. How they can connect should be even greater than it is now.
I totally agree. Yeah, I think it'll enable richer conversations with a more informed patient that has agency over their own healthcare. And it'll also open up clinicians to do other things versus kind of educating on the fundamentals. Now they can actually be a better team in caring for the patient. So with that, Andrew, thank you so much. I know we ran over time. Thank you for your generosity in being here. It was a pleasure to meet you. And I look forward to meeting you in person at the World Medical Innovation Forum in a few weeks from now.
Likewise, I hope you have a great day. Thanks again.
That was Andrew Trister. Now, unnatural signals.
What we're watching at Verily isn't about devices or dashboards, it's about translation. They began by building tools. Then they realized the real leverage was in helping data speak the same language. Once information can move, systems start to change on their own. Andrew's reflections on leapfrogging matter because they remind us that progress doesn't always come from upgrading what exists.
Sometimes it comes from skipping it entirely. In places without heavy infrastructure, care can move closer to people faster. The signal here is simple. Better health doesn't start with better biology. It starts when information stops getting stuck.
Thanks for listening to Unnatural Selection. If you enjoyed the episode, subscribe, leave a review, and share it with someone shaping the future. Explore more at unnaturalselection.net and connect with us on LinkedIn and Facebook. Until next time, keep evolving.